spare capacity, that is capacity that isn't at the normal standard. So we've had to spread ourselves more thinly, and we have developed guidance to try and make sure that continues to be safe. But if we had to expand even more and spread ourselves even more thinly, there would be concern that safety could be compromised. So everyone is working really well. We're doing everything that we can, but staff are genuinely concerned. And then that, on top of concerns about availability of PPE, the testing issues and everything else, means that staff are under increased stress. And we need to make sure that not just doctors, but nurses and all the allied health professions that work with us to provide critical care, that they remain resilient so that we can see this pandemic through to care for patients, and also to be able to continue to provide that care afterwards when we start to get back to normal.
Thank you very much, Dr. Pittard. We'll come back to you if we may, but I'd just like to go now to Dame Donna Kinnear, and I'd like to thank you for the incredible courage we're seeing from nurses. As I think you said, their work is always up close and personal and at high risk to themselves. Perhaps you could tell us what the situation is like on the front line for nurses, both in hospitals and in the community.
So if I start with hospitals, I know that this week I personally worked as one of those nurses that isn't a critical care nurse, but helping critical nurses on the front line in the Nightingale Hospital in London. And what you see there is that nurses are working incredibly hard, but so are others. Allied health professionals. I worked with a clinical scientist this week who is taking on the role as a health professional. So there is an issue with capacity, but there's also an issue that actually when people are volunteering, you don't get the same staff all the time. And therefore, that's where you sometimes are compromising the safety standards. Because although we're all up fit and, to do the work, you are only one critical nurse to a range of other people trying to deliver the care to those in an intensive care environment. So I think on the front line, people are working, they're changing and adapting the way they work, but they are concerned. So even in some of our environments, such as the Nightingale, people have become ill. There is an issue about how we get nurses and others to be able to be tested, because actually it's not quite clear. So you would expect an employer, if you started to become ill, that you would be able to have a defined place to go to, and your employer, occupational health, would instruct you where to go. What I'm hearing from the front line is nurses are sometimes just driving 2 hours, feeling very unwell with possible symptoms of coronavirus, and driving to a testing station. And sometimes if you haven't got an appointment, you're turned away, only to be told to come back another time. So we need some really clear direction of how we can access testing, both in the NHS, but more so for social care, because they don't have the same infrastructure as the NHS. So for me, there is something about our STPs giving clear instructions to the hospitals or social care outlets in their environment about how to get tested, so that people aren't turned away, that we can make appointments, and that people that are feeling very unwell with those symptoms can get access to this.
Thank you very much. We'll come back to you as well if we may, but that was very helpful. I'd like to turn now to Professor Costello. Now, you've been a very prominent critic of the government's approach to testing so far. And on April the 4th, the Health Secretary announced this big target of 100,000 tests a day. Just like to ask you to what extent that has assuaged your concerns about the overall approach the government is taking.
Yes, I mean, look, if we're going to suppress the chain of transmission of this virus in the next stage, we all hope that the national lockdown and social distancing will bring about a large suppression of the epidemic so far. But we're going to face further waves. And so we need to make sure that we have a system in place that can not just do a certain number of tests in the laboratory, but has a system at district and community level. And listen, I pay huge tribute to the people in the front line, the intensive care nurses, doctors, and the like. But there's also a massive transformation going on right now with general practices, with the public health, local authority outbreak management teams. And it will fall on them to put in place a system that enables you to test people rapidly in the community, in care homes, and to make sure that the results are got back to them very quickly, and that we also maintain social distancing of a kind after we lift the national lockdown. And if we can do that, then we're going to be focusing on the people we really want to lock down, which are cases and contacts. I mean, as the WHO has said all along, you need to find cases, you need to test them if you can, you trace their contacts, you isolate them, you do social distancing, but most important of all, you do it all at speed. And the harsh reality, and one of the reasons I hope I've been constructively critical, and also I believe we should not have any blame at this stage. We should have a no blame audit. Where were the system errors that led us to have probably the highest death rates in Europe? And we have to face the reality of that. We were too slow with a number of things, but we can make sure that in the second wave, we're not too slow. Actually, I'm not sure we need 100,000 tests per day. In reality, if we can get this epidemic damped down, more important is to have the systems in place. And I'd like to know much more from Matt Hancock. You know, how are they restructuring the public health teams? Have they got plans in place? Will they need additional volunteers, for example? We've got 750,000 people queuing up. I bet there's a lot of retired doctors and nurses there that could maybe come in and help with some of the contact tracing, being online, giving that personal service, because just asking people to self-isolate is not going to achieve the quarantine you want to. Now, Korea did it with testing and apps. We need to hear about apps. China and a lot of the Asian states did it by symptomatic identification and then careful quarantining, some in hospitals, people with milder symptoms in special places where they could rest, and others in hotels, actually. So we need to think this all through, because all of them right now in Asia are facing little flare-ups, and we will face the same, and we need to damp that down. So it is the number of tests, and I think we will get there now that we've widened the reach of who is helping with the testing. But we have to have the systems and the logistics in place so that we can suppress this and maintain it for a long time. And that way we'll get the economy going again.
Thank you very much. Well, my colleague Tom Tugendhat's got a question for you, Professor Costello, and then I'm going to come to Luke Evans, who's got a question for Dr. Pittard.
Professor Costello, thank you very much, and thank you very much for the impressive work you've done in publishing your thoughts as well. I've been reading them with great interest. May I ask, what are the implications for the spread of COVID-19 in the developing world, and what actions should the UK be taking alongside international partners? I've spoken this morning with heads of UN agencies who are deeply concerned, not just at the spread of the disease, but also the implications of the lockdown in terms of widespread famines and perhaps social and even civil unrest.
Well, you're absolutely right. I mean, most of the poorer countries will find social distancing extremely difficult because of many people living in shanty towns, you know, one-room accommodation. You're seeing this mass migration of laborers in India, for example. India actually does have testing capacity, but they've got a massive population. But most countries in Africa will struggle to test. They won't have, some countries have no more than a couple of ventilators. They probably don't have intensive care units sufficient to deal with it. So on and personal and protective equipment, of course, is going to be a massive issue. So on all of those counts, there's going to be a crisis. We're only just starting that because they're a couple of months behind us. I know a lot of the agencies, the usual aid agencies, and of course, DFID has a great reputation in many countries for giving aid and making sure it gets to the right places. I think there has to be a coordinated effort. We do face potentially incredibly high death rates if the epidemic behaves in southern countries the way it's behaved in northern countries. It's possible there'll be some seasonal issues there and that the southern hemisphere might be relatively protected for a few months, but we don't know about that. But clearly, the aid issues, the support to the countries we usually support, the agencies that are doing work like WHO, like UNICEF, and like a number of the others. All of these are big issues, and I hope that the UK can play its part, not just to obviously get it right for our country, but also to make sure that we're very generous to the southern. The other is you're right to mention food security and also the economic impacts, because the real risk is that they're going to see big unemployment rates without social security, bankruptcies, and a huge new debt crisis, because they will have loans in, dollars and stuff that they won't be able to repay. So all of these things require not just doctors and nurses. This is for economists and for aid specialists.
Can I just follow up briefly and just get you to touch on why this is important for us? Forgive me, we're responsible for the money and the welfare of the British people as members of this Parliament. And I just wondered if you could touch on why it is so important that we do not allow ponds of disease, as it were, in other parts of the country, in other parts of the world, and the potential implications for that coming back to the UK, and why this is so important for the UK.
There's that, but we're also a trading nation, and clearly, if we get the economy going, I mean, Africa has actually been the fastest growing region of the world in the last, decade. If they collapse, that's going to be both a burden on aid for everyone. There's going to be migration. There's going to be flight, and the economy that we deal with, and particularly after Brexit, we're looking for new markets, will be very important. The other thing is longer term from a foreign policy point of view. I mean, we've seen that, President Trump has cut budgets to WHO, which I think diminishes the status of America. China is actually delivering an awful lot of personal protective equipment and testing capacity to many countries in Africa. And I think the long-term impact of that may be that people will start to turn to the East rather than to the West for help. And I would hope that we would preserve our strong reputation, really strong reputation for aid. We've always kept our aid budgets up under whichever colour of government. So I do hope that that will be maintained. And to remember that, with open borders that you need for trade, you're going to have the risk of people bringing imported infections in if we don't get control all over the world.
Thank you very much. I'd like to bring in Luke Evans for a question for Dr. Pittard.
Dr. Pittard, thank you so much for all the frontline staff are doing. And you're right, your allied professions who are coming in and stepping up. For vascular surgeons doing ABGs and things like that, I hear it from my clinical friends. I'm just intrigued from the Faculty of IT, from the ITU perspective. Were you guys consulted about the Nightingale hospitals and the setup, and how much influence have you had in that process?
So the Faculty of Intensive Care Medicine hasn't had direct input into development of the Nightingale hospitals, but I do know that clinicians have been involved in looking at sites, looking at how they would run, and there are a number of different clinical models that are being used, and that really depends on the geography, the population density, etc. So, for instance, in London, they were aware that their critical care capacity in London wouldn't be enough to deal with every critical care patient. So the Nightingale XL Centre would be used to manage critically ill patients. Whereas some of the other Nightingale hospitals, if within that geographical area, the critical care facilities, including the surge capacity within the normal hospital footprint, could manage with the critically ill, then those Nightingale centres would probably be used for either the less sick or for those patients when they're recovering who, rather than staying within the hospital, could then be moved out to the Nightingale hospital, and that would free up capacity within the normal hospital footprint for those who were sicker. And that's a sort of model that I think will need to be looked at as we start to get back to normal, because we know after being critically ill, it takes a long time to recover, irrespective of what takes you into the intensive care unit. And it can take 12 to 18 months to get back to the sort of place you were at before you became critically ill. And that's an area, life after critical illness, which is actually a work stream that the faculty is currently engaged in, is something that we'll need to look at, because if patients are staying in hospital when they don't necessarily need it, but they need that increased support and that rehabilitation, then that's going to hinder the speed with which we can get back to normal healthcare practice afterwards.
Thank you. And if I could just follow up on that, because you partly touched on where I was going with this. And so I'm aware of the criteria, for example, the amount of neuroadrenaline that patients should be on when they're transferred. I just wondered on the first point is, do you think coronavirus patients are stable enough to be able to make a judgment call whether or not, if they're going to be effectively a step down ITU at the Nightingale, is that something that you think is clinically possible? And in terms of that rehab, those slow to wean patients, have you got any ability of predicting that, so that if they're in the Nightingale hospital and, as you point out, take a long time to recover both from the intensive care unit and longer term, who should be picking that up, and does the ITU have the capacity to be able to deal with that?
Okay, so to deal with your first question about transferring patients, we transfer critically ill patients all the time based on their clinical need. So if a patient presents to hospital X where those clinical services aren't available, and a classic one would be neurosurgery. So if a patient has a subarachnoid hemorrhage, a brain hemorrhage, and they present to a smaller hospital, they will get transferred to a larger hospital that has a neurosurgical centre. So we transfer patients all the time, and we do it in a safe way. And therefore, we would not transfer a patient who we thought it was unsafe to do so. And myself, my clinical colleagues in critical care are highly trained to be able to say which patients are suitable to transfer and what isn't. So it won't be undertaken if it's not safe. To come to your second question, that there are two issues about recovery from critical care. There's the issue when you're still in the acute phase. So when you're not too concerned as a clinician about whether the patient is going to survive or not. It's about when they build up the strength to be able to get off a ventilator. And that might be something that could be undertaken in a Nightingale hospital to take off the pressure of the acute main hospitals. And again, that's the sort of thing that critical care is used to doing all the time. But even when those patients are well enough to come off a ventilator, they then have a long journey in front of them in terms of not just getting home, but getting back to the quality of life they had before. So something simple as getting back to work is a sort of a major indicator of when somebody is starting to make a good recovery. And it can take 12 to 18 months to get to that point. And of course, if you can get back to working, you're then contributing to the economy. And that is a major area that we in critical care are aware that isn't actually adequately resourced at the moment. So the faculty is engaged with a group of experts to try and produce some guidance as to what would need to happen. Because obviously, if we can get patients out of hospital adequately supported by the right people, and we currently have follow-up clinics and we manage patients, but we don't have the resource to do that. And if we can get people back to work, back to contributing to the economy in the longer term, then that will be really beneficial for everybody.
Thank you. I think we've probably got time for a couple of brief questions before we bring in the Health Secretary, but Paul Bristow and then Clive Betts.
Thank you, Jeremy. I just wanted to follow up with Professor Anthony Costello, some of the points that Tom made in relation to the impacts on the UK from infection in the developing world. I'm thinking particularly India, Pakistan, Bangladesh. There are, of course, many British nationals living over there and dual nationals living over there. And if they are likely to see considerable outbreaks there, they will understandably want to come back home. What could be the impact on the UK of that type of migration back to the UK, and how and can we manage this?
Yeah, I mean, first, look, in the UK, this is not a single epidemic. This is It moves into cities like it did in Wuhan. It then went out to 4 cities in China, which they suppressed very quickly in about 2 weeks with partial lockdown. Same in Korea. In this country, it's been in London, Wolverhampton, and maybe a bit in Liverpool and Glasgow. But the rest of the country is largely, or was untouched up until March the 12th. There were 50 local health authorities that had less than 10 cases there. So I was against the idea that you should stop contact tracing in those communities. It was right to stop it in London because it was too difficult. So we have to, and the recent estimates, even from the chief scientific officer, is that after this wave, which could kill, we could see 40,000 deaths by the time it's over. We could only have maybe 10, 15% of the population infected or covered. And so the idea of herd immunity would mean another 5, 6 waves maybe in order to get to 60%. And I think we should be not using phrases like flatten the curve, because that implies continuing. We've got to suppress this right down. Then you run the risk of both community transmission within the country, and if you open the borders to people coming in, not just from the developing world, but from Europe, from anywhere. So you're going to have imported cases, and in China, they've been watching incredibly carefully, and they have picked up mainly imported cases, but now they're seeing some transmission, the same in Singapore, Hong Kong, and the like. So that's the challenge. We're all playing for time. We need to damp it right down. We need to have a community protective shield to try and keep it that way. And then we've got to pray that the vaccinologists come up. And, Professor Sarah Gilbert from Oxford is saying, she's 80% confident she'll have a vaccine by September. So we've got to be positive here, keep everything down, stop the deaths, keep the economy open as much as you can with that, without a national lockdown, and then hope that we get a vaccine.
Thanks. I think we've got a brief one from Laura Trott to Professor Costello.
Thank you. It's following on from Paul's question. So we had Professor Doyle from Public Health England giving us evidence a couple of weeks ago, and she told the committee that intensive contact tracing was not effective when there is community transmission. Do you agree with that, Professor Costello?
No, I don't. I agree with it in areas of hotspots and intense transmission. Obviously, then it becomes much more difficult, and your focus in London and other hotspot areas would shift to protecting health workers. But in many, I'm in Yorkshire right now. They had less than 10 cases identified, confirmed cases in a population of 300,000 or 400,000 around the time that we stopped all our community testing and contact tracing. I would have had a more nuanced view whereby in quieter areas you maintain that. And of course, now that we've got national lockdown and we're suppressing the epidemic, the aim must be now to get all the logistics set up with digital apps, with public health teams, maybe with volunteers and with primary care, who've all been doing this, I think, to then have an absolute plan to protect the community as soon as we lift the lockdown, and then focus on the people we really want to lock down, which is cases and contacts. And then we can let the economy get going again. And this has been backed up by the Nobel Prize winning economist, Paul Romer, who's shown very elegantly that if you focus on that, it's much less disruptive to the economy. And Chris Whitty has talked a lot about the indirect effects on mortality. He's absolutely right, from economic damage, bankruptcies, unemployment. We have to get the economy going. And if it means locking down 10% of our population, even giving them incentives to stay in quarantine, and with digital apps to help monitor their symptoms and give them support, that's the way to really keep this going until we get a vaccine and safe herd immunity.
Thank you.
Thank you. And a final brief one in this part of the hearing from Sarah Owen for Dame Donna.
Thank you. We heard this week changing guidance from the Secretary of State around visitors, particularly around end-of-life care. Do you think that hospitals have the resources and the correct PPE in order to facilitate this and to do it safely?
Well, we're currently worried, very, very worried about the shortage of PPE, particularly gowns in hospitals, as we've heard on the BBC this morning. So I think if we can actually get more PPE into the country, then we will be able to do that. But as of this moment, I am very worried that we don't have enough PPE for staff to protect themselves, let alone facilitate giving it to relatives to be able to see their loved ones during end-of-life care.
Thank you. That concludes this first part of the session. I'd like to say a very big thank you to Dame Donna, to Dr. Pittard and to Professor Costello for your very informative answers to our questions. And I now want to move on to the main part of this morning's proceedings, which is with the Health Secretary, Matt Hancock. I'd like to welcome you to this session, congratulate you on your own recovery from coronavirus. Thank you for your own huge efforts during this crisis, but also ask you to pass on through yourself our thanks, first of all, to your team at the Department of Health and Social Care, who are working extremely hard, but also to NHS staff more broadly, who we all know are doing an absolutely superhuman job at the moment. So thank you for joining us this morning. Now, you asked yesterday if you could have a few moments at the start of our session just to set out what you think the state of play is and your battle plan. So please do go ahead with that.
Thanks, Jeremy, and thanks very much for having me. And I think it's very important that we have these sessions, and I'm delighted that Parliament is operating in this virtual format. I thought it was just worth starting by setting out the way we approach the things that we need to do to protect the health of the nation. And we think about this through our battle plan, which has 6 elements, and some of these we then put more detail on already in the public domain. The first, of course, is social distancing, and everybody knows where we're up to on that after the decision yesterday to extend the social distancing measures. That, of course, is mission critical for bending the curve down, and that is working. The second part of the battle plan is building up NHS capacity, because making sure that the NHS always has the capacity to treat patients is also mission critical. And thus far, that has always been the case. As of this morning, we have the highest figure again of spare UK wide critical care beds of 2,769. And of course, the NHS Nightingale project, which has been an unbelievable rollout, is a critical part of making sure we've always got NHS capacity, and the ventilator project plays into that, and there's a whole load of parts to it. The third element is supply, which we have as a separate strand in our battle plan because it is so challenging. And if you think about it, what's happened is that suddenly the world has needed a huge amount more of a quite small but very important list of kit. That includes PPE, the key medicines, again, the ventilators, also the medicines, the standard ICU medicines that are needed, and the potential treatments as they're coming down the track. Everybody's buying up hydroxychloroquine in case the clinical trials demonstrate that it is a very effective treatment, because that's what the early signs say. The fourth part is testing. I'm sure we'll come to testing. Clearly, the ramp up of testing is very important, but we put testing in with test, track, and trace, because testing on its own is very important especially for staff and for treating patients. But for controlling the spread of the disease, you need the testing, the tracking technology, and the large-scale contact tracing. And it's the combination of the 3, test, track, and trace, that we have. That is our fourth part of our battle plan. The fifth is vaccines and treatments, because clearly the more that we can have treatments that mean that the morbidity and mortality from catching coronavirus are less severe, then that obviously changes the impact of the disease on society. And the more that we can do on treatments, the more that we can, the less dangerous the disease is. And obviously on vaccines, where we have, the UK is playing an absolutely world-leading role, but there is still some time to go. And the reason that there's still some time to go is because the mortality and morbidity is relatively low from this disease, and terrible as the death toll is, the relative proportion of people who sadly die is relatively low, and therefore you do have to test vaccines because of the risks of putting a vaccine into the general population, which itself does damage. And then the sixth part of the battle plan is shielding, because the more that we can protect those who are most vulnerable, the safer the safer society is from the disease. So they're the 6 parts of the battle plan, and you can see, I hope, that all the different things that we have to put into those 6 parts. And overall, the goal is clearly to bend the curve down, and to make sure the NHS capacity is there, and at the same time to do the work to try to improve the ability of us as a society to cope with this disease, and therefore with the goal that we can lift some of the incredibly restrictive measures that we've had to place on the population in order to get the disease under control. Which I would just end my opening by thanking the NHS staff and social care staff who are doing amazing work, and I'm very grateful for you for opening with that. But also to thank the public, because it's only because the public have the vast majority followed the rules that we're now seeing the flattening of the curve.
Thank you very much indeed for that. I want to start with the reporting of data, because that's something that where I think people have been puzzled. And could you just explain why it is that we're only reporting hospital deaths on a daily basis?
So the overall goal here is to be as transparent as possible, and the quality of the data is the critical part to the answer to this question. So we have daily reports of deaths from COVID-19 or people with COVID-19, whether it's deemed by the clinicians as the direct cause or somebody dying with COVID-19. We have that in daily reports that come in through the 4 NHSs in the 4 nations and come into a central point and are then published. The data of deaths of people who have COVID-19 and die outside of hospitals takes longer to collect, and that's because it is recorded on death certificates, and death certificates are often written a couple of days after a death. They're not always written at the same time as the death, and then they're registered and go into the registry, and then the data can be published. So the reason that the ONS publishes with a lag the overall number of deaths as opposed to deaths in hospital is it is a data collection issue. Every death in any setting matters and is an important part of our analysis. Of course it is. And we have managed to work with the ONS to bring forward the publication of overall deaths of people with COVID-19 to, I think the lag is now 5 days, whereas when it started it was 2 weeks. So the ONS have done good work to bring that data more up to speed. But naturally, because everybody's looking at the number of people, this data, not only to understand what has happened, but also to try to understand where we are with the transmission of the disease. I understand why people want that up to date. We rather than holding the hospital's data back until we had the whole data, we think it's better to publish the hospital's data when we have it and then publish the overall data when we have that.
Okay, we've got a lot of questions to get through, so if I could possibly ask you just to be fairly brief on the answers. You talked about the ONS. They say there have been 217 COVID deaths in care homes to date. Now, Scotland thinks it's a quarter of all its COVID deaths are in care homes. France, Italy, Spain think it's about half their COVID deaths are in care homes. Does it really seem likely to you that less than 2% of our COVID deaths are in care homes?
No. And the figure that you mention is a figure from a couple of weeks back. And so is I'm absolutely sure that both the number and the proportion are, I could say with a high degree of confidence that the number and the proportion are higher than what you say, and I'll wait for the official statistics to understand it.
I just wonder why we can't do what France does and just collate that information on a daily basis and publish it on a daily basis so that we all know exactly what the situation is.
Well, my understanding is that that isn't what the French do. I know there's been a lot of attention on the way that France publish this data, but they do publish it a couple of times a week. And as I said, we've worked with the ONS to try to reduce this lag. And we're also now working, because I'm concerned about this as well, I asked the CQC to make sure that we record the data in care homes specifically of those who are residents of care homes, whether they die in hospital or in the care home. And they started collecting that data yesterday, and it will be published very shortly. So I have introduced a new measure that will directly address this question.
Okay. Now I want to bring in my colleague Sarah Owen, but I just want to ask you finally about something very sensitive, which is you said this week that 27 NHS staff have sadly lost their lives in the process of this terrible crisis. Do you have an update on that number? Is it still 27 to your knowledge?
The official verified figure remains 27. It gets updated 3 times a week. And I will let you know as soon as I get an update. Sadly, I have seen, we've all seen reports of Mary, the nurse who was pregnant and in the late stage of pregnancy, and an NHS nurse and died since the publication of the previous figures. So we know that the figure is higher.
And will you commit to publishing that number 3 times a week when you have it?
Yes, I'd quite like to get it to daily.
Thank you very much. I'll bring Sarah Owen now.
Thank you, and thank you, Secretary of State. At the last meeting of the Health Select Committee, I asked 3 times about guidance for pregnant healthcare workers. As you've just said, we've now tragically seen the death of 28-year-old Mary Agiwa-Agipong at Luton and Dunstable Hospital in my constituency. The current guidance on pregnant healthcare workers during this pandemic comes not from the NHS, but from the Royal College of Midwives and from the Royal College of Obstetricians and Gynecologists. And if I may, it states, it may not be possible to completely avoid caring for all patients with COVID-19. As for all healthcare workers, use of personal protective equipment and risk assessments according to current guidance will provide pregnant workers with protection from infection. The arrival of rapid COVID-19 testing will significantly assist in organising care provision. And this guidance will be updated appropriately when tests are commonly available. Now, despite continual promises to ramp up the distribution of PPE and testing, healthcare workers on the front line have been left wanting. So will you commit to ensuring that there is a review of the guidance for pregnant healthcare workers in light of the delays in PPE distribution and testing being a long way off commonly available? And will you commit to seeing that revised guidance coming straight from the NHS and government?
Well, there's several things to answer in that question, Sarah. The first thing is to say that we work very closely with the Royal Colleges, and whether guidance comes from the Royal Colleges, Public Health England, or the NHS, we try to ensure that guidance comes from the most appropriate body for that particular group, and we work very closely together. So whether guidance comes from the Royal Colleges or from the NHS is a is much less important than what the guidance says and what the situation is on the ground. With respect to your constituent, Mary, her death was incredibly moving, I think, to so many people, not only in the NHS, but across the country. As was made public at the time that her death was made public, she hadn't been in work for a month. And but we look into every single death of somebody who works in the NHS to make sure that we fully understand it. So the making sure we get to the bottom of each and every one of these cases is incredibly important. And that also includes, the access to the protective equipment, of course, and testing. So finally on testing, we've now made testing available to everybody who needs it across the NHS. So all staff who are symptomatic now are able to get tests. And I can tell you that over 50,000 people who work in the NHS have now had tests. So the good news is that we're able to expand, because we're expanding the capacity to test, therefore we're able to expand the number of tests that are done, not only on, for instance, patients going to care homes, as I announced earlier this week, but also on for NHS staff and members of their households if a member of NHS staff is isolating because of household isolation.
Thank you. We'll come back to testing and PPE later, but Yvette Cooper had a question on this point.
Thank you very much. Health Secretary, just a very quick factual question. Do you have an estimate for the number or the proportion of NHS staff or social care staff who have been infected with COVID-19?
No, I don't. What I have is an estimate of the proportion who are off work because they either have suspected COVID-19 or a household member does, which is a little over 8%. And obviously with the expansion of testing, we have to be able to get that figure down.
Thank you. I've got Tom Tugendhat and then Taiwo Olteme.
Thank you. And Matt, please do pass on as well, our thanks as well to everybody in the NHS who's doing an amazing job, not just for British citizens here, but of course many others from around the world who are in the UK. And on that basis, can I ask, what agreements have you been able to come to on reciprocal arrangements for British citizens abroad and other citizens here, so that British citizens overseas can also access care wherever they happen to be?
Well, it's a very important question, Tom, and one that we went through in the debate around Brexit. And we have also reciprocal healthcare arrangements with a small number of other countries in the world, like Australia. I would like to expand that. We had to drop the legal changes to do that during the Brexit parliamentary process. But it's something that I'd like to see us expand those formal reciprocal arrangements around the world. Now, of course, first and foremost, one of the principles of the management of epidemics is that people should be treated by the health system in which they find themselves ill. So you'll remember that the very first COVID-19 patient here in the UK was a Chinese citizen who'd come to visit, and we treated him and his one of his parents in Newcastle. So that is the overriding principle. However, we're also highly pragmatic, and we have run a huge effort that no doubt you'll be aware of, that Dominic Raab has led, in order to ensure that people can come back to the UK because of the collapse of the international travel system as it was before the crisis hit. And that repatriation has both been for people who are ill and people who aren't ill. And it's been particularly challenging and acute for people on cruise ships because they do not have a nation of residents. But the time taken to get a cruise ship back that's on the high seas would have been, in many cases, too long, given that there was an outbreak on board. So there's been a huge operational side to this that you're better asking Dom about than me, but also there is that overriding principle that we treat the people who are here.
Well,
Thank you. Oh, sorry, Tom, quick one.
Oh, sorry, no, come on. We will, of course, ask Dom about the practicalities, as you rightly said. The second thing I just wanted to ask very briefly on the international aspect is, clearly, in a pandemic, learning off others is absolutely essential. How are you finding transparency and openness from other countries is affecting our ability to respond and keep our people safe? And what conversations have you had with countries that are successful, like, for example, Taiwan?
Well, we do have conversations with colleagues right around the world all the time, and especially the regular G7 discussions. There's a G20 set of G20 discussions that are coming up this weekend, and with countries outside of those sorts of formal settings. Especially early in the crisis, there were issues around quality of data, but I think everybody is doing their level best to get the best data that they can. I mean, as right from the opening of the question at this select committee, there are challenges in getting the right data and getting the data out. My task is to use the very best data and try to understand the countries where certain things are going well, also try to understand countries where things aren't going so well, and to learn what's gone wrong, as well as what's gone right. So we do talk to countries right around the world, and we're constantly trying to learn.
Thank you. Now, I want to make sure we have plenty of time to ask on testing and PPE. So final three brief questions on this section on data from Taiwo, then James Murray, and then Rosie Cooper. Do we have Taiwo?
Can you hear me?
Hello, Taiwo.
Hiya. Good morning, and Secretary of State, and thank you for coming up. This is regarding actually PPE. So just yesterday, a nurse at my local hospital spoke about her experience on the front line. She described the low morale among staff due to the lack of support, and she comes home every night crying after a 12-hour shift. Now, Megan said, and I quote, that she's scared and terrified given the lack of PPE. Now, due to the nursing shortage, those on the front line are scared and afraid about the virus. What I want to know is, what support are you giving to ensure that nurses and other professionals feel safe, and you're addressing the lack of morale amongst these teams?
Well, this is an incredibly important question, and could I just ask, which is your local trust?
University Hospital Coventry in Warwickshire.
Okay, so this is it's incredibly important, because morale of those who are on the front line is so important. And people talk about some of the things that the public do to show their value, and I know from talking to people in the NHS and in social care that they really matter. Things like the new care badge has gone down very, very well amongst people in social care, and I'm really proud of it. But these things are only a part of the story, because making sure that people have the support that they need, exactly as you say, when they're in work, is so important. This is why we'll come on to PPE in detail, no doubt, but this is why PPE is absolutely critical. It's also why the expansion of testing to NHS staff and to social care staff when they need it is I'm very pleased that we've been able to do, because we've been able to ramp up the amount of testing so fast. And the final thing I'd say is that we pay tribute regularly to the staff in the NHS. The fact that we have the staff and the physical capacity, for instance, through the Nightingale hospitals with the ventilators, to be able to treat everyone who needs it, I think is a really big positive thing that we've been able to achieve during this crisis. Because it means that NHS staff are not having to make decisions about who gets the treatment. Of course, we've got to resolve the issues around PPE and keep expanding testing. But making sure that we have that capacity, not only the physical capacity, but also the staff, is a very good thing. And we've had staff returning to the NHS, almost 10,000 nurses, and I'll try to get the overall figure. And that's been something that I think people have seen, and people really value the things people have done there as well.
Thank you. Tyler, is it PPE? Could we come back to that in the PPE a bit later?
I was just actually talking about morale.
Okay, why don't you ask that then? Go on then. Ask that.
I've spoken to a lot of pharmacists over the past weeks, and a lot of them have expressed their concerns about the fact that a lot of frustrated customers have been attacking them. And some pharmacies have resulted into hiring security staff. Now, what I want to know is, what is the government going to do to ensure that these frontline workers feel safe and they're not subjected to abuse whilst they're actually doing their job?
Yeah, well, I'm really glad you picked out pharmacists, because I think, pharmacists are a critical part of the NHS family. And because they work in the community, they're often closer to the communities who they serve, and they're part of the NHS. So we've put extra funding into pharmacy, an extra £300 million, because of the challenges that they face, and in particular high demand for medicines, so to help them with their cash flow. We're also working with them on PPE, and not only on having the equipment, but also making semi-permanent changes. So, for instance, putting glass screens up so that there's a lower amount of transmission, a lower risk within pharmacies, and supporting them to do that. And so pharmacies are an absolutely critical part of the NHS team.
Thank you. And Taiwo has a background as a pharmacist, actually, which is why it's important that she asked that question. We're just going to have two final brief ones on data from James Murray and then Rosie Cooper.
Thank you, Chair. And my question is just really to understand how we're using the data to make sure the strategy is right in different regions, and in particular, in my case, in London. Because on the 2nd of March, you wrote in the Evening Standard, Secretary of State, your actions would always be guided by the expert scientific advice. Then on the 17th of March, the government chief scientific officer told this committee that London is ahead of the rest of the country where it is on the outbreak at the moment. So putting to one side the question of whether the government was too late in waiting until March the 23rd to introduce lockdown measures nationwide, why did you not, at the very least, apply them sooner in London?
Well, it's an important question. I think that we took the right measures at the right time. We did consider having a London-specific lockdown and decided that it was better to do it across the country as a whole. That's for two reasons. The first is that if you put a lockdown in one part of the country, then there's still travel from there to the rest of the country, and so it isn't as easy as that. And the second reason is that actually one of the really strong things that's come through this this crisis is that the country is acting in lockstep. And if you look at the response to the social distancing measures, they've been very similar across the whole UK, and really the country's come together. And to separate off one part of the country from the rest actually has downsides in terms of the national unity that we've seen in the support for the overall response. These are incredibly difficult measures, and it's the national unity that has been shown in response to them has been extraordinary. So these are difficult judgments, as you say, based on the science. We did consider a separate London policy, and we decided it was better that the whole nation moves together.
Thank you. Final question on this bit from Rosie Cooper.
Thank you. Thank you. Can you hear me?
Yes.
Yes, you can.
Right. Sorry. Thank you, Secretary of State. I acknowledging that everybody is working tremendously hard in the health service, top to bottom, and that I accept all the statements that have been made in good faith. But I'd like to address the elephant in the room, and that is the question of trust and confidence, both of the public and of clinicians and people working in the health service. So ignoring the World Health Organization's test without giving any real public health reasoning, so far a lot of people feel they've had statement after statement after statement. Within days and weeks, those statements fall apart. That's on PPE, on testing, and testing not being needed in care homes, things like this. I mean, the testing centres that have been set up in out-of-town areas, it could only have come from the centre. Somebody who's got no idea locally how people are supposed to travel miles and miles and miles to get tested. They might as well be on the moon, frankly. So we've got a whole list of statements which are aspirational, we can regard as aspirational rather than factual. So hope isn't a strategy. So out there, what's your message to the people who go out to the front line every day, expecting their PPE, expecting the rules to be applied to everybody and for them to make sense and to be supported? So, Secretary of State, what assurance, not reassurance, can you give to people that the basis for the decisions that you're making and taking are real? For example, everyone, we could ramp up testing in hospital labs. We don't do that, and yet we're still talking about 100,000 tests. So overall, how can you tell people to go and risk their lives without giving them the evidence to do that?
Well, there's quite a lot to unpack there, Rosie. I'm not sure I agree with your assessment at all. The first thing is that we've had a principle of this throughout this whole crisis of transparency being at the heart of what we do. And we've published enormous amounts of data and information. It's true that if you want to make something happen, you have to say what you plan to happen, and then follow through on that. The 100,000 tests per day by the end of the month is a clear goal and commitment, and I set it out in public to galvanize the life sciences industry, and that's exactly what's happened in response to it. So. And I could go through a couple of the other things that you put in there. The morale on the front line is absolutely vital. I've now got the figure. The current COVID-related absences are 7.1%, which is lower than the previously publicly reported figure of 8%, which shows that that's coming down. That's partly because we have expanded testing to NHS staff. You talk about the test drive-through centres. These are a big policy success so far. We've now got 22. We're going to have 50 right across the country. That's precisely to get the testing capabilities out into the community. And then once we've got those established, we're going to have mobile units. And then when the technology is good enough, we will have home testing kits as well. So that's, I say that not to set out hope. I say that because I'm setting out our plan for what we're going to deliver. And as for the overall public confidence, I'm just really pleased that the public have followed the advice that we've given in very, very high proportion. And that has had the consequence of overall doing the most important thing in this crisis, which is to flatten the curve so that we can see that over the last 10 days or so, the number of new cases and the number of new cases arriving in hospital are both flat, which is very, very good.
Thank you.
Secretary of State.
Okay, Rosie.
Secretary of State, I would just ask the Secretary of State to think about the actual implementation locally. Doing all this centrally and not doing it, these out-of-town testing centres, really difficult. You're not getting the throughput you should have.
Well, we'll come on to that in testing, but there is spare capacity there that we need to use, yes.
Thank you, Rosie. Well, that was a good bridge into our next topic, which is testing. And the first thing I want to say is you announced, Secretary of State, a very ambitious target of 100,000 tests a day on April the 2nd. That's been widely welcomed. Could we just start with an update, not on capacity, but on how many tests were actually conducted under each of the pillars of that programme yesterday, so we can have some sense as to how we're doing?
Yes, I can give you those data. I'm just trying to, I'll just get hold of them. The overall number was just over 18,000 yesterday, so a rise of 4,000. And the vast majority of that was in Pillar 1. The number in Pillar 2 was around 4,000. We haven't got any tests that are good enough to work clinically in Pillar 3 yet. And the number in Pillar 4 was a couple of hundred. I'll get the exact numbers for you, Chair.
Okay. Thank you. Would it be possible, as this is so central to what the government's doing, to publish these numbers on a daily basis so that we can just see exactly how the progress is happening?
Well, we do publish the number. You mean broken down by pillar?
By each pillar, yes.
By all means, we can do that, yeah.
Thank you. Now, given how critical testing is and how we can look at countries that have done the most testing and they seem to have the lowest death rates, one thing that puzzles people is why we stopped community testing on the 12th of March. You could, for example, have announced the 100,000 daily test target on the 12th of March. And if we'd done that, we would have been ahead in the global race for the reagent chemicals. We could perhaps be testing everyone who leaves hospital now. We could be testing more people in care homes. So why the 3-week gap between stopping community testing and the announcement of the 100,000 target?
I don't think if we'd announced the 100,000 target a couple of weeks earlier, as you suggest, we would be in any different position now, because we were continuing the drive to increase testing all along. The challenge is that the radical increase in the amount of testing over the last 2 months, from 2,000 tests a day at the start of March to 10,000 tests a day at the end of March, and now with the ambitious goal I've set of 100,000 by the end of this month. That ramp up has been ongoing throughout. I set a public target in part because people were asking how fast are we going to get there, and because it also managed to galvanize the non-diagnostics pharmaceutical industry here. The diagnostics part of the pharmaceutical industry, which is brilliant but relatively small here, had been heavily engaged throughout. But the overall project to ramp up testing has been going since day one. Now, the challenge is that as the epidemic increased exponentially at that point in the middle of March, it meant that the incidence of the outbreak was broad, and it meant that we weren't able to test everybody with symptoms. But I want to get back to the position, now that we've got the curve under control, I want to be able to get back to the position that we can test everybody with symptoms. And I anticipate being able to do that relatively soon, because we're increasing capacity, as I say. And I can now give you the full figures for yesterday. At midday yesterday, we'd done 18,665 tests in the previous 24 hours, 16,166 from Pillar 1, 2,323 from Pillar 2, and 176 from Pillar 4. So the history of, I know the history of testing is going to be a long debated subject. What really matters is what we're going to do from here on in. And what I can tell you is that today we're able to expand the eligibility for testing, which is currently for patients, for surveys, and for NHS and social care staff, and some that go to LRFs for people, for local urgent need. I can today expand the eligibility for testing to police, the fire service, prison staff, local authority, critical local authority staff, the judiciary, and DWP staff who need it. And we're able to do that because of the scale up of testing.
So if we just look at a country like Germany, they have a population 25% bigger than us, but only a third the number of deaths. They actually never stopped testing in the community. They've carried on right the way through. And on your strategy under your 5 pillars, mass community testing doesn't appear as one of the focuses, the main focuses of any of the 5 pillars. Now, it might be that it is there, but I think the thing that's worried people, and maybe you could clear this up, is that Dr. Jenny Harris, your Deputy Chief Medical Officer, said that community testing was not an appropriate intervention. Yvonne Doyle said that the ship had sailed for community testing. So is the government view that mass community testing is part of the strategy, or do you think the ship has sailed?
It is part of the strategy. We will be introducing it when we can. It wasn't possible when we had small numbers of tests, but as we have expanding numbers of tests, so it'll be possible. And the way that it'll be delivered is under both Pillar 2, as we expand the commercial swab testing capabilities, and under Pillar 3, when we get a mass antibody test that has a high enough specificity for us to be comfortable putting it into the community.
Okay, so as you said earlier, it's not just the testing, it's the tracking and the tracing and the quarantining. Dr. Lee of the Korean Centre for Disease Control told the Science and Technology Select Committee last week that there were up to 1,000 people doing contact tracing in Korea, alongside all the digital apps. PHE had 290 people doing this at their peak, but they now say that's been wound down. Are we going to be building up those teams again?
Yes.
And is that going to be something that will involve local government, central government? How are you going to do it?
We plan to do that through a central team. It'll be run as part of the test, track and trace strategy, which is one of the pillars of the overall battle plan. Now that brings together teams from NHSX who are leading on the design of the app with a huge array of partners that are under the that are working within that. From Public Health England, who are the experts in what we refer to as external contact tracing. This is where you get somebody else comes in and helps you to work out the contacts that you need to get in contact with, and then goes and helps you contact them. There's also, when this is, the app is itself a contact tracing app. That is the point of it, is to be able to assist individuals to do contact tracing themselves by notifying people who they've been in close contact with when they've downloaded the app. And then, of course, link that to testing so people can get the tests. So the test, track and trace is one piece of work with those 3 critical strands, and then you have to have a quarantine policy to back it up.
So you have Kathy Hall, who's your official in charge of testing.
Yes.
Has she got someone working directly for her who is full-time just on the contact tracing side of this?
So the way this is organised inside the department is David Williams, who is the second permanent secretary here at the Department for Health, is responsible for test, track and trace overall. Matthew Gould, who's the chief executive of NHSX, runs the app part. Kathy Hall runs the testing part. And Duncan Selby at Public Health England is responsible for the contact tracing element.
Thank you. And a final question from me on this one. Yesterday, Dominic Raab announced the 5 tests that would need to be passed before we exit the lockdown. Now, the WHO guidance for ending lockdowns actually has 6 criteria that countries are advised to follow. And the second of those 6 criteria is that there must be capacities in place to detect, test, isolate and treat every case and trace every contact. So if we are going to be able to end the lockdown in 3 weeks, if that's going to be a theoretical possibility for the Cabinet to consider, do you accept that we would need to get comprehensive contact tracing in place by then if we're going to be following WHO guidelines?
Well, we do need to have comprehensive test, track and trace in place as soon as possible. And we need to get the technology right. We need to have the people, and we're building that resource. And obviously we need to have the testing, and we're ramping that up as well. So we do need to have all 3 of those in place, and we're working incredibly hard to make sure that they are.
But you accept that we couldn't lift the lockdown if we were going to comply with what the WHO advised, until we've got that contact tracing, that mass contact tracing in the community in place?
Well, the answer is that it depends on scale. So the scale of contact tracing that you need depends on the incidence of transmission, not on the R. So the R, which we've heard a lot about, is the rate of transmission determines how fast the incidence of transmission goes up or down. And so what matters for the scale of contact tracing that you need is essentially the number of people who are catching the disease. It's the incidence of transmission. If you start with a high incidence of transmission like you've got now, then you need a massive contact tracing capability, whether that is e-contact tracing or external contact tracing. And then as you bring the incidence down, which we plan to do once we've seen the flattening of the curve, we now need to drive that curve down. Then, of course, the amount of contact tracing that you need reduces over time.
Thank you. I'd like to bring in Greg Clark, followed by Clive Betts.
Thank you, Jeremy. Secretary of State, my committee, the Science and Technology Select Committee, has heard international evidence that a very high proportion of people with COVID-19, it's at over 50%, are asymptomatic themselves, but can infect others. Yeah. Have you received expert representations that asymptomatic NHS and care workers should be routinely and regularly tested?
This is something that we are looking at. The asymptomatic transmission of COVID-19 is one of the novel features of it. It is not typical amongst coronaviruses and is one of the single most difficult things that has caused this pandemic to be so severe across the world. And the answer to your question very precisely is yes, that's something that we're looking at, and I'm talking to hospital chief executives about.
When do you think you might be able to make a response with actions on that?
In the coming weeks.
And
this plays in. This is all determined by the by capacity within testing and by the gap between the testing that we are doing at the moment, as I read out the figure 18,665, and the current capacity as of today, which is 30,000 across pillars 1 and 2. That means that we have capacity for 10,000 more tests a day than we did yesterday, which I find, given that the pressures on testing is frustrating. And we want NHS staff to come forward, and I've also expanded testing to social care staff and to more residents in social care, and now today to other public services like police, fire, and prison staff and others. And one of the further things that we're considering but have not yet been able to take forward is mass testing of asymptomatic staff within the NHS.
Thank you. It's obvious that if we're going to test asymptomatic people within our care settings, as well as expanding to care workers and others testing, we're going to need much more testing.
Yeah.
Now, you've talked about ramping up testing capability, but it's important that we should learn the lessons as we go. That's the basis on which science proceeds. The approach that was taken from the beginning by Public Health England was a centralized and a sequential approach. First of all, we started with the central lab, and then the 12, I think, Public Health England labs, then expanded it to NHS. So it was done sequentially. Other countries, we know, including South Korea, did everything at once. They had a decentralized approach, and they did everything from the outset, and that meant that rather than having to ramp up capacity, more was available. Now, a decision was made to reject that model. Sharon Peacock, in evidence to my committee, said that had been considered and rejected. So the first thing is, will the the evidence that informed the choice to reject that model be published. It was nearly 4 weeks ago when Sharon Peacock committed that she would do that. It's important that we should be able to see it. And learning the lessons going forward, and it is important to do this, when it comes to the wider deployment of antigen tests and subsequently of antibody tests, and indeed we hope vaccines, will this approach of being centralized and sequential be revised in the light of the evidence?
Well, we're ramping up on all of the pillars, and as you know, some of the pillars are the delivery of the in-house capability, like especially Pillar 1, Public Health England and NHS labs, and other labs that can contribute. And then the pillar 2 and 3 are very much commercial based in parallel, bringing the commercial capabilities of the that we can get our hands on to bear. And that is so that is happening absolutely in parallel. I didn't know about the commitment to publish any evidence behind PHE's original decision, but I'll certainly look into that.
Thank you.
Bets, and then we've got Laura and Yvette.
Right, thank you, Jeremy. Secretary of State, we've rightly given our thanks to all those in the NHS doing such a wonderful job for us, but I'm sure you'd want to join with me in also thanking everyone in local government, whether those in social care, those organising volunteers, or those in public health and environmental health, who are really contributing enormously to the battle against this virus. So it's that issue about environmental health and public health capacity that I want to ask. You've rightly highlighted the need for testing and then contact tracing and tracking. Local government, public health and environmental health are going to play a very, very important part in that. But we know in the last 10 years that austerity has meant massive cuts to those services in terms of the resources they have. Are you confident, talking to your colleague, the Secretary of State for Housing, Community and Local Government, there is now the capacity there and the ability to really ramp up and deal with that programme in the way that we need?
Well, I think it's incredibly important that we do, Clive, and I agree with you about the thanks that we should give to everybody working in local government, especially the public health departments, and across the board, and of course in care. In social care, one of the things I'm really proud of in this crisis is that the country recognise the commitment and and thank those working in social care just as much as the NHS. You know, I've said before, it's clap for our carers, it's not clap for the NHS. Both are wonderful and making an amazing contribution in a very difficult circumstances. And that's true also for wider local government staff. And I'm glad today we've been able to extend testing to local government staff who need it. On the financial point, I also agree with you that we need to make sure that obviously the public health capabilities as well as the social care responsibilities of local government are properly funded. We've put in a total of 2.9 billion extra since the budget in order to support, and the Chancellor has said that he'll do whatever it takes.
Right. And does that mean, therefore, that if we are going to move significantly to the contact tracing and tracking, which you mentioned, that local authorities are going to have a major role to play in that? It isn't just going to be about apps. There's going to be a lot of physical hands-on work, that local councils are going to be fully compensated for that.
Well, to the extent to which local authorities are needed to do that, then of course they'll be compensated for it, yes.
Sorry, you said that the extent to which they are, surely public health and environmental health officers are going to be absolutely key to getting that done, and it's going to be done at a local level, isn't it, if we're going to get it right?
Well, no, we haven't made that decision, not least because the interaction with the contact tracing, with the app is critical. And whether it's done locally or whether it's done through phone banks at a national level, that decision is not yet made. So, but if it is done through local authorities, then of course, they'll be paid to do the job.
Well, Secretary, do you accept, though, that apps are clearly an important part of this and a way forward, but for many people, perhaps those who are most vulnerable, the elderly, for example, not always really comfortable using new technology. For them, actually physical contact tracking and tracing done at a local level, maybe in the end, the only way you're going to get a comprehensive approach to it.
Well, there's absolutely the role of people in contact tracing is very, very important. These things are complementary, but what I can't prejudge, and I'm sure you'll understand this, is a decision about exactly how to organise that. Because
when are we going to know that? Is there a date for that?
We haven't got a date, but we will publish more details on this soon. But the point I'd make is that so much of this is done over the phone. Going round to somebody's house isn't always necessary. It may be necessary, and I can see the point about having a local angle to it. But given the scale of contact tracing that is likely to be needed, doing this nationally over the phone has a lot of advantages.
Thank you, Chair.
Okay, I'd like to bring in Laura Trott and then Yvette Cooper.
Thank you, Chair, and thank you, Secretary of State, for coming along today. I want to ask a question about managing the supply and demand of testing. So you mentioned earlier that we have capacity for 30,000 tests. We're carrying out 18,000 tests. I know my local CCG has said to me they've got a capacity for huge amounts more tests than are actually being carried out. I know from today, from the expansion, which is very welcome to local government, firefighters, etc., that will take up some of that excess capacity. But what is being done centrally to make sure that we are using resources where they're needed and that we're kind of managing the system in that way?
Well, this is an incredibly important question. It's a real challenge because you want to match demand to supply. I don't want massive queues and inability to get appointments at the drive-through centres. But I do want the drive-through centres to be fully used. Of course I do. Everybody wants that. This is a problem that's come up over the last week as capacity has increased. At first, it looked like it was a problem due to the Easter weekend because the number of people wanting to come forward for testing over the weekend was lower than expected. But we've also found that within the NHS, the number of staff coming forward for testing is lower than was anticipated. And you'll understand why we had a priority order for the use of the test, where it was patients first, then NHS staff. Frankly, the number of NHS staff coming forward wasn't as high as expected. And therefore, we extended it very quickly to social care and to both to residents and staff in social care. But because capacity is going up sharply, I'm therefore able to expand it further, and we'll expand it again as soon as the capacity is there to use to make sure that capacity is used up. So we have a priority order and we're running through it, and it includes the suggestion that was made. I think it was from you, Jeremy, that we should also test asymptomatic people in hospitals and in care homes as part of the survey strand, which goes alongside all of this, so that we can find people who are asymptomatic but carriers of the disease and may also transmit it, and also so that we can understand the prevalence of the disease especially in hospitals and care homes.
Thank you. Two quick follow-ups to that. So if there is excess demand in one area and excess capacity in another, is there someone who is matching that up within Public Health England or the NHS?
Yes.
Brilliant. And then secondly, just in terms of NHS staff, carers accessing tests, is there a way that we can increase communication as to how they do that? We had some evidence earlier that in many places it's slightly unclear, although obviously it's very welcome that numbers are going up overall.
Yes, so as far from a policy level, it's very clear, but I understand that this is policy that changes relatively rapidly, and so cascading that to the front line is a challenge. In policy terms, if you're in the NHS, go to your line manager, and if you're in social care, then you go to the your line manager, and the social care organisation should go through the CQC. The CQC are playing a very important role in this. So it's really clear how to get hold of the test. That's all written on the website. The question is, there is an operational question of cascading that information to those who are symptomatic right through the system.
Thank you. Yvette Cooper.
Thank you, Health Secretary. Germany, Italy, South Korea, New Zealand, Australia, Canada, Austria, Greece, Ireland, Singapore, many more countries all ask people who are arriving in the country to self-isolate or to quarantine for 14 days. In the UK, we don't have any of that. On the 13th of March, around the same time that we stopped the community testing and tracing, we also got rid of the guidance which said that people arriving from high prevalence countries like Wuhan and Italy and so on at that time should self-isolate for 14 days. Why don't we have any guidance like that on self-isolation for people coming into the country? Why aren't we taking a precautionary approach?
Well, we have the same guidance for people to self-isolate when they arrive as if you have symptoms here, and we have facilities to ensure that people who arrive and are symptomatic can self-isolate even if they don't have anywhere to go to. So the NHS has a contract with hotels to put people in those hotels if they arrive and display symptoms. So we do have that capability, and it's true that when the current incidence of the disease in the UK is high, and given that there's been a collapse in the number of people travelling internationally, that is it is not. I'm advised by the epidemiologists. It is not an epidemiologically significant route of transmission in the UK because the current incidence is high. Of course, if we succeed in getting the incidence of transmission lower and much lower, which I hope that we will, then you have to ask the question of how to protect the UK from people who have been in a place where that incidence of transmission is much higher.
It's very difficult to understand the nature behind this decision because, I mean, reported 130 countries have some kind of requirement or restrictions or border at the border, like isolation or testing or other forms of restrictions, and we don't. So it's hard to see why the advice to us, the science that you're talking about, is somehow different for the science that every other government is looking at across the world, especially given that you haven't published any of this analysis and science. I understand that obviously if the staff on the airplane spots somebody who is coughing heavily and so on, there may be extra provisions at the border. But given the asymptomatic issues and so on, it is hard to understand why you don't have some kind of precautionary approach for self-isolation or quarantine, because you did have at the time before when you had community testing and tracing in place. And even if these are a small proportion of the overall number of transmissions taking place in the country at the moment, a small proportion of a very large number is still an awful lot of people. So will you at least publish the analysis behind this decision, and will you look at it again in the light of what other countries are doing?
Yeah. So I disagree that we're not doing anything. I set out what we are doing, and it's similar to many other countries who are following the science. But of course, I can absolutely commit to keeping this under review because you've understood precisely the reasoning behind the current policy, but that policy is dependent on the current situation, and many things change fast in this epidemic.
But if you were actually trying to minimize the number of transmissions completely, you would still be trying to minimize the number of transmissions coming from abroad. Even if there are a higher number of transmissions happening elsewhere, what this looks as though you're doing is it looks as though you're not actually trying to stop any transmissions that you can, and you're just looking at broad brush policies. Why would you not try and prevent every possible transmission, including for people arriving from abroad who may be very easily able to self-isolate? You're not actually asking them to do anything very hard.
Well, that isn't what we're doing, as the way you characterise it, and we follow the science on this, as we do on the decisions that we take.
Would you publish the science? Will you publish the science on this?
Very happy for the chief to ask the chief medical officer to publish the explanation behind the decisions that we've taken. Absolutely, yes.
And the analysis behind it as well, not just the summary.
Thank you very much. Thank you very much. I want to now move on to the issue of protective equipment for health and care staff. And if I could, I just want to ask you about an issue that's been in the media this morning. Are you confident, Health Secretary, that all our hospitals will have enough gowns to see them through the weekend?
Well, the challenge of getting protective equipment out to everybody who needs it is an incredibly difficult one. Firstly, it's a challenge of logistics, because suddenly over a short period of time we've gone from needing a small amount of protective equipment to needing a very large amount of protective equipment. Just to give you a bit of context before I answer the question directly, we have, as of this weekend, we will have shipped 1 billion items of personal protective equipment across the UK. So this is I've called it a Herculean effort before. It is a massive undertaking. And it's understandable in a massive undertaking like that there are complications and that there are challenges. And I take responsibility for getting PPE out to everyone. This isn't a responsibility. Of course, there are many players in it, and a hospital chief exec has to make sure that the PPE gets from where it arrives in the hospital to the right part of the hospital. But we take responsibility for the delivery of the whole system. We are tight on gowns. That is the pressure point at the moment. We have another 55,000 gowns arriving today, and we're working on the acquisition internationally of more gowns. But it is a challenge, and this follows changing the guidance 10 days ago. Which increased the advice on the use of gowns, but also said that they should be used for sessional use rather than for individual patient use. And it is a big challenge delivering against that new guidance, and we're doing everything we possibly can. My team are up, up all night. We have a 24-hour operation because the team in Beijing and some of the other embassies around the world are working through the night on that acquisition.
But just to so the public understand, based on the information you have in front of you now, are going to be able to get gowns to everywhere that needs them over the course of this weekend?
Well, that is exactly what we are aiming to do, and then there is a question of exactly what type of gown, which is a technical question where of course that has to be signed off by the health and safety executive. That's how we define what type of gown is the right type. So we work closely with the health and safety executive to make sure that we use all of the different types of gowns that are safe to be used.
Thank you. Can I just ask you about PPE in social care? Now, at the moment, the guidance doesn't require PPE to be worn in care homes for non-COVID patients. And this puzzles a lot of people, because if those same patients, about 400,000 people across the UK, were living at home, they would be in the shielding category, and all the home care workers that came to look after them, to wash them, get them up in the mornings and so on, would be required to wear masks. So why does the guidance not require that? Why are we taking that risk with residents in care homes?
So I do not think we're taking a risk in that way with residents in care homes. I'm very happy to look at that particular point in the guidance. I can see why people might read that as an inconsistency, and I'm very happy to take that away.
Could you write to us?
Very happy to.
Thank you. Now, one social care provider, which actually has a home in my patch, Leonard Cheshire, they look after about 3,000 residents across the country. They say that it's been a battle, but they have got basic PPE now for all their staff. But what they can't get is any of the higher level PPE. And so they have nurses, for example, who are doing what are called aerosol generating procedures, which means their staff could be getting infected if they get sprayed by a patient, and they could indeed pass that on to other residents. Many in the social care system feel that they have not had equal access to PPE as the NHS has had. What would you say to them?
Well, what I'd say is that it is vital that everybody gets the PPE that they need according to the guidance that's been agreed by the clinicians and set out. And that's what we're working incredibly hard to do. What I'd also say is the challenge is that many social care settings have normally bought PPE through their normal commercial suppliers. And because of the scale of the increase in PPE needs, those commercial suppliers have found it difficult to restock. And ultimately, we have a global shortage of PPE. There is more PPE being demanded and used across the world than there are supplies. So that's why ramping up the domestic supply is also incredibly important. So I think people, just to finish off on social care, because I think it's a really important point, we've thought carefully about the different use of PPE in different settings. And for me, it is just as important to get the right PPE to the right people, no matter what their setting.
So would you allow social care providers for the higher level PPE to access the NHS supply chain if they can't secure it on the open market?
Oh yes, we've absolutely. That's one of the big changes that we've made. We're rolling out what's called the Clipper service to social care because the NHS supply chain has brought in an online delivery and request system. If you think about it, the NHS supply chain traditionally has been an organisation that gets kit to about 230 hospitals. We now have a responsibility to deliver PPE to 58,000 settings. So NHS supply chain has gone from what is essentially a wholesale distribution to a retail distribution in a very, very short amount of time under intense pressure. I think they've done an amazing job. We've then brought in Clipper and the Army in order to bolster their logistical capabilities. It's been incredibly difficult, of course, I don't deny that. The team have been working incredibly hard on it, and I pay tribute to them, and I think that they deserve our thanks. Because in getting PPE out to everyone, I understand the pressures that it in the system, and I understand why people feel so strongly about it. But the one thing that I can be absolutely sure of, hand on heart, is that everyone in the system is doing all they possibly can to get the right PPE to the right places.
Thank you. Just a final one from me. I just want to ask about a group of people who aren't talked about as much as they should be, and that's the home care workers.
Yeah.
People who go around to people's homes. There's about 500,000 of them across the country. See about between 5 and 15 people every day. Now, a back of the envelope calculation suggests that that group alone will need about 150 million pieces of PPE between now and the end of May. Are you going to make absolutely sure they get it?
Yes, they are part of the team across health and social care that I worry about. We've got there's around 10,000 different locations from which the people who talk about those who work in domiciliary social care and go out to people's homes. There's about 10,000 locations they work from, and they are part of the 58,000, which includes them, the care homes, pharmacists, primary care, all of the different touch points of the NHS and the social care system, who all need and deserve to get PPE.
Thank you. Now, I've got lots of questions from committee members. If I could start with Dean, and then I'll go to Amy, James, Paul and Clive. So Dean.
Thank you. And first of all, Secretary of State, can I thank you and your team for being so reactive over the past few weeks. Whenever I've had a question, I've got a response very quickly, and thank you. I've got two questions, which I'll try and be as brief as I can. First one is on PPE. From chatting to frontline workers, what I'm hearing is that some of the anxiety that's happening is because of the changes in the rules around PPE. So obviously Public Health England put their guidelines out, which were different from the WHO guidelines, and then more recently that shifted to WHO guidelines, as I understand it. And I think that's caused some concern around actually why didn't we do that from the start? So if you could answer that. And then the second question is actually not PPE related, but it's a critical one for my constituents and elsewhere in other hospitals. As you'll be aware, we had a critical incident in Watford a few weeks ago around oxygen. I'd just be interested to know, what's been done to ensure that there aren't any more of those issues happening either at Watford, but also at other hospitals across the UK.
Well, they're both very important questions. So on the first, of course, on exactly what PPE is required in what settings, you'll understand I have to take clinical advice on that. However, I wasn't comfortable with clinical advice that even though it's what our clinicians had concluded was the best outcome, was the best advice, was not at the level set by the World Health Organization. And if you think about it, in part, this is about the PPE stocks that had been built up and fitting the proposals of what people should wear when to what the stocks are. And I think that instead I said we've got to be at WHO standards or higher, and the clinicians that came forward with that upgrade, and I'm very glad that they did. Now, of course, also, PPE must be used according to those standards and not higher, and that's why we set them out in such a clear way. And we've got to make sure that that people know what to do in the circumstances where PPE supplies are tight. But this is something that we're constantly working on, and the core answer to your question is that it is. I'm guided by the clinicians in terms of what PPE is right in what circumstances. On the second point, of course, the supply part of the battle plan has PPE as one of the most high-profile elements, but it has a huge amount in it, and making sure that the oxygen supplies work is very important. And I think it was almost 2 weeks ago now that we had a problem because one of the oxygen machines, one of the pumps, broke at Watford, which meant that we had to divert patients coming in by ambulance to other local hospitals. I'm glad to say that no patients had a problem, and there wasn't a risk to patient safety. The situation was managed extremely effectively, and we brought in technical experts to sort the engineering problem that there was, and the supplies of throughout the NHS, we're looking at strengthening where they're old or out of date, those oxygen supply, the physical equipment, and it's an important technical problem.
Okay, and can I just follow up to a very quick PP thing on the question around the access to that? Can you just confirm that no nurse or doctor who wants to perhaps use some additional PPE because of concerns are going to be policed and told that they can't if they're concerned about what they've been asked to wear?
No, exactly. But what I would say is that the clinical guidelines have been thought about very carefully, and we have to make sure that the PPE that gets to where it gets to where it needs to be. It is, as I've said before, a precious resource, and the reason that it's precious is because globally there is there's very, very high demand, and so getting hold of it is a huge challenge, and it's one of the reasons that we're ramping up the domestic manufacture to make sure that we have more that's made here and can go straight into the front line, whether that's in the NHS or in social care. So PPE is a precious resource, and we need to make sure that it's used carefully.
Thank you. Amy Callahan. Do we have Amy?
Yep, thank you. Hi. Secretary of State, I understand there's widespread concerns regarding the availability of PPE. I represent a constituency in Scotland where concern around PPE procurement is high, given conflicting media reports and statements over the past couple of days. Can you please specify the alternative arrangements that you've stated are in place for Scotland and Wales around PPE procurement?
Well, we have a UK-wide approach to PPE. Although the NHS and social care, of course, are devolved, I have an overarching responsibility for the response to a public health crisis right across the UK. And I work very closely with my counterparts in all 4 nations. We've seen, for instance, in Northern Ireland, we sent a shipment of PPE to Northern Ireland, and they sent gowns to England because they had more gowns than they needed, and we were short of gowns. So this sort of this team effort right across the UK is incredibly important. And I speak to my opposite number in the Scottish government, and we make sure that we work it as best as we can. We've shipped a total of 11 million items of PPE from England to Scotland, so I suppose that is the that demonstrates just what a team effort it is.
Thank you very much. James Murray.
Thank you. I'd like to ask the Secretary of State for his comments on the reports earlier this week about the reuse of protective equipment that was reportedly under consideration by Public Health England as a last resort measure. I want to ask the Secretary of State by what date he can tell us today the supply and distribution issues of PPE will finally be resolved so that this last resort measure can be ruled out.
Well, of course, where there is a shortage in an individual setting, then of course it's reasonable to follow World Health Organization guidelines on what to do in those circumstances. And in some cases, the reuse of PPE is advised by clinicians. So this, again, I come back to the point that this has to be a clinical decision. I would love to be able to wave a magic wand and have PPE fall from the sky in large quantities and be able to answer your question about when shortages will be resolved. But given we have a global situation in which there is less PPE in the world than the world needs, obviously it's going to be a huge pressure point. I mean, there's nothing that you can there's nothing that I can say at this select committee that will take away the fact that we have a global challenge, and we're doing everything that we can to resolve it to get that PPE to the front line.
Okay, but Secretary of State, you say that there is a global challenge here and everyone is facing the same issues. But if you look at the example in Ealing, the borough where my constituency is located, they have gone in with other boroughs, neighbouring boroughs, to procure their own PPE equipment for care homes because they don't rely on the national system to be able to deliver it for them. We also see today, ITV were reporting their survey, 54% of carers say they don't have enough PPE to do their job safely. And what I would like to ask you is that, how can we trust the figures that you're giving out about what's going on in care homes when what's being reported from the front line is so different from what you're saying? That survey I referred to said that 42% of carers said that they were looking after residents with suspected COVID-19 cases, but you said only 15% of care homes had recorded cases. Now, I appreciate the lack of testing means you may not know the true numbers, but won't you admit that your 15% looks like a substantial underreporting of the true case on the ground?
There's so many things I need to just correct in that question. If I just go through it. The first thing is, I think it's terrific when a local organisation is able to get hold of their own PPE. After all, other than in these extraordinary and unusual circumstances, the whole social care sector gets its PPE that it uses as standard from normal commercial sources. Likewise, many hospitals get their PPE from all sorts of different routes, not just the NHS supply chain, which is the national system, but get it from abroad, get it from local manufacturers. That's terrific. This is that is part of the system working. So I pay tribute to the way that Ealing are working, and I hope you would too. On the point about numbers of cases in care homes, I would expect that figure that currently the latest public figure is that 15% of care homes have an outbreak, and by that an outbreak means 2 or more cases. I would expect that figure to rise. The figure is in fact robust in terms of its measurement, because we do test residents in care homes when they're symptomatic, and we've so far tested over 10,000 residents of care homes when they're symptomatic. So it's not true to say that we haven't hitherto been testing residents in care homes. So, this is a really, really important area to get right, but it is important to base it on the facts.
Paul Bristow.
Secretary of State, there have been reports that state manufacturers in the UK who are now making fantastic efforts to produce PPE are finding it takes weeks to get their kit certified. I just want to ask, is that the case? And if so, can this process be speeded up?
Yes.
Or where there are particular shortages, perhaps even waived?
Well, this is really important. And it's true that PPE should be certified by Health and Safety Executive according to the existing rules. And we have worked hard with the Health and Safety Executive to speed up that certification program. And in some cases, especially of relatively large consignments coming from abroad, the Health and Safety Executive have worked rapidly to certify. But if there's individual cases where that's gone slowly, I'd be very happy to look into it and to work with the Health and Safety Executive to make sure that it works properly. But and rapidly. But you raise another really important point, Paul, which is that the domestic manufacture of PPE is a critical part of us building up our capacity. And I pay tribute to the companies that have already moved over some of their domestic manufacture to PPE, not just Burberry and Barbour, who we hear about from their clothing manufacture, but also things like Diageo turning some of their alcohol production into hand gel. Because although it's less of a problem now, we did have a big shortage of hand gel a couple of weeks ago, and Diageo came to our rescue because hand gel is largely based on alcohol. So that's so there is this domestic effort, this national effort to make PPE is really important. And when you have a global shortage, even though of course we started with a massive stockpile, we've run through that stockpile, not entirely, but a large part of it. And we need to be buying from abroad and making it at home. So we need lots more companies to come forward and help us to make the PPE that people need.
Thank you. Clive Betts?
Jeremy, Secretary of State, you got a fairly strongly worded letter, I think, last week from the directors of adult social care, where they described the department's approach to social care as an afterthought. And in particular, they described the national PPE supply chain as shambolic. That's not just about the amount of PPE around, but how it was being distributed, shambolic. Do you accept that criticism? What have you done to put it right?
I don't. I thought the letter was a bit unfair on the people who work in my team, who are doing everything in their power to get PPE to the front line. You know, as I said before, with the support of the Army Logistics Corps, who are amazing, and changing a distribution model from distributing to just over 230 hospitals to delivering to 58,000 different locations is a mammoth, huge task. And so, and the truth is that a very high proportion of local authorities have played a big role in that. Also, since that was published, we've published the Social Care Action Plan, which we were working with ADAS on and addresses many of the points that were made in the letter. So I hope that we've made some progress.
So you think the supply chain is working well now?
I would say that the supply chain is working very hard, Clyde, to get all of the PPE to the front line where it's needed.
And when will all care workers, including those going into people's homes, which was rightly mentioned, it's not just care workers in residential homes, when will they all have the PPE they need?
Well, the answer to that is as soon as possible. And I wish I could wave a magic wand, but I can't.
Can I finally ask you mentioned stockpile a few minutes ago, but the figures from your own department show that the amount of PPE available in the stockpile was reduced by 40% in the last 6 years. Hasn't that contributed to the problems we've got now?
Well, no, I think that was unfair, but it's a tricky question for me to answer. It's the first time this has happened on this select committee, Clive, because that was before I was Secretary of State. But I may have to defer to the chair, but I did ask the officials to look into this, and they found that accusation not to be fair and not to be a reasonable accusation to level either me or my predecessor.
Okay, so you say the figures are wrong?
I'm saying that that particular accusation, which I'm aware of, we've looked into and it's not right.
Okay, thank you.
Thank you very much. Now, just two final areas we want to ask you about. One of them is treatments for coronavirus, and the other is the impact of coronavirus on other treatments like cancer that might be interrupted. So if we could just go on to treatments first, Secretary of State. I just want to start, you talked earlier about hydroxychloroquine, which is being used in France. Some people think there's great potential in plasma treatment. The World Health Organization seemed to think that the Ebola drug remdesivir is very promising. If we were to conclude a drug is safe, would we shortcut the normal processes involving randomized control trials and so on, put the orders in and get the drug out quickly?
Well, I'm going to bring Professor Van Tam in, who's electronically sitting beside me to answer this question. But just before I do, I thought it might be worth me setting out the principles. The principles are that, of course, we want to get the very best treatment to the people who need them. And we will follow the science. And the science is best supported by having rigorous analysis of which drugs work. And thus far, there have not been any clinical trials that I am aware of around the world that have conclusively proved the value of these different drugs. However, we have started to use them on patients here in the UK because the early evidence, which is not verified evidence, shows that they have some value. But all drugs also have downsides. And so the approach we've taken here is that, yes, to get people access to these drugs, but to do it within the structure of trials to make sure we also get the evidence of what works. For instance, you mentioned remdesivir. I saw some evidence just this week about the value of that particular drug, but when it was interrogated, you found that there wasn't a base against which it was compared, and therefore it wasn't the full science has not yet been concluded on drugs like that. So yes, get the drugs to the people who need it, but also make sure that it's done in a way that's structured and we can get the proper scientific verification out of it. So that's the that's the approach that we've taken. But JVT will be able to add far more detail than I can. He is our top expert and is one of the world's top experts in how to do this.
Thank you. I'll come in at this point, Secretary of State, and say that for the committee, we absolutely don't know what works at the moment. We have limited reports from China and other parts of the world that certain things might work. But what we don't have is proper comparisons between treatment and not. And one of the problems you get into is if you just use a drug and you give it a go, so to speak, is that the population of patients in whom you give it a go are very often sicker and quite often different to the ones in whom you don't need to reach for the treatment. And we know with COVID-19, the range of disease severity is very broad, from very mild to very severe. And so if we don't kind of hold our discipline and do the randomized trials where we can actually compare these treatments against each other and against supportive care, we will never know definitively what really works and what doesn't work.
So can I be very specific, because I did ask a very specific question. I asked, once we knew a drug was safe, would we short circuit the normal requirement for randomized controlled trials? And you're saying no, it's very important we do them. Is that correct?
I'm saying we need to know that a drug is both safe and effective, and we need to know from the clinical trials who are the best patients to use that drug in. It may not be the whole population. There may be unexpected or intolerable side effects in certain age groups, types of patient. And also, we need to understand at what stage in the illness the drug will work. And that's why we've got a clinical trial, a very, very large one, very fast recruiting, 200 to 300 patients a day going into this trial, that begins at the doors of the hospital when somebody's admitted with COVID-19, but we have another trial in the intensive care unit.
Okay, thank you. But I just so I understand this. So what we're saying is that we are going to carry on following the normal processes, because some people say, well, obviously you wouldn't want to give a drug to someone if there were side effects, but once you know there aren't side effects, once you know it's safe, some people are saying that we should carry on and try these drugs before you know if it's effective, just because time is of the essence. But if I may, I'll go back to the Health Secretary now, because I've just got one follow-up, if I may, to...
may I just come back on that point?
Of course, yeah.
Yes, it is. You talked about safety in terms of side effects, but it is also possible that some of these drugs may worsen the outcomes of COVID-19 itself. And if we don't do the trials, we won't get on top of the side effects, which for the common drugs such as hydrochloroquine, frankly, at this point, we already know. But we won't get on top of whether the effects are zero, positive, or negative. And whilst it's highly unlikely that we're going to get negative findings, one can't actually rule it out with a totally new illness until we do the science and understand what works, what harms, what doesn't.
Thank you. So I've got the message. It's a belt and braces approach. Could I go back to the Health Secretary?
Jeremy, it's not just a minute. It is not a belt and braces approach, because we are allowing people to have access to these drugs. We are doing it within a rigorous scientific structure. That is the correct approach. It is not belts and braces because we're accelerating the clinical trials, as JVT says, much faster than usual, and allowing people access, but doing it within a structured approach is undoubtedly the best way forward.
Okay. I just had a brief question about a letter that Sir Robert Francis has written to me, which he's also copied you on. Now, this is about the concerns of doctors essentially worried about having to play God if they had to make a choice between two patients and there was only one intensive care bed or one ventilator available. And luckily, at the moment, the capacity seems to be holding up, and long may that last. But his concern was that there isn't a national framework which allows doctors to make those choices. So they could be subject to criminal action at a later date for not giving someone the care that they clinically needed. Now, Professor Powis told the Select Committee a few weeks back that national guidance would be issued. As I understand it, it hasn't yet been issued. Could you just give us an update on that?
Well, the good news, Jeremy, is that we don't need to issue the guidance. So, in a way, the horrific nature of the choices that are outlined in that letter from Sir Robert, and the deeply unpleasant situation that it puts doctors and clinicians in, is yet another reason why it has been so important to ensure NHS capacity is always greater than demand. And, you know, it's one of the things that in this crisis, of course, I'm very happy to answer questions on PPE and testing, but, you know, the really big thing that the overwhelming of our NHS, which was expected by many people at the start of this crisis, we have avoided through a huge amount of effort from a huge number of people. And that means that we don't have to put out guidance that which was called for in Sir Robert's letter.
Thank you. So Taiwo and Yvette wanted to come in on this issue of treatments.
Thank you. Secretary of State, there's been a shortage of vital medicines across the country. This is particularly affecting patients with rare or complicated diseases, such as children with severe epilepsy. Now, in order to prevent such patients from being hospitalized or needing intensive care, will you use your emergency power to help these vulnerable people and provide the funds needed to meet the prescription costs of drugs such as medicinal cannabis in this crisis?
Well, thank you for that question. I suppose, as the question demonstrates, there are always challenges with access to some medicines. For instance, over the summer we had a problem of access to HRT medicines, which was very significant for the women affected because of a problem of supply in a factory in Germany, and we worked very hard to address that. And so there are shortages from time to time amongst the 12,500 medicines that are used in the UK. Now, on medicinal cannabis, the position has not changed since we last improved it and allowed for the importation and changed the border rules around importing medicinal cannabis products. So it's an important question, but it's separate from COVID response, and we have made progress over the last year on that. Again, it comes down to having the right evidence for both effectiveness and safety of the drugs. There is a COVID specific challenge, which is that clearly the drugs needed around the ventilation of a patient have been much in demand across the world over the past couple of months. And we have in the UK, we did put out one alert to recommend the switching from one particular intensive care drug to another one that had exactly the same clinical effects, and so it didn't have any impact on patient safety at all. That's exactly the sort of thing that you do when there's a biosimilar drug available that, but under a different branding, for instance, when there's a shortage protocol. But so far, we've been able to keep the supply chain going. There have been a couple of moments when it was difficult, and I've been involved in talking to my opposite numbers around the world to make sure that the supply chain for drugs has always made sure, coming back to the point I made in the previous answer, that the capacity the NHS to treat people with COVID-19 has always been there, and that is my absolute top priority.
Thank you. And then just finally on COVID treatment, Yvette Cooper.
Thank you. While you have some additional critical care capacity, have you looked at using it to intervene earlier and to treat more patients with oxygen at an early stage, given that there have been concerns about people being sent home again after being looked at an early stage and then deteriorating, or alternatively not coming to hospital until it's too late?
This is a decision that always has to be a clinical decision for each individual. I'll ask JVT to answer on the details of it, because this is exactly the sort of thing that he'd provide the advice to me on, and so he can provide the advice direct to you.
Yes, so thank you for the question. We do understand that this is an illness which is generally lasts 5 to 7 days and is generally self-limiting. But in the proportion of patients who unfortunately end up being hospitalized, often the deterioration is later on at the kind of 5 to 7 day point in the illness. And so from that perspective, one can understand the reports of people being seen initially and potentially having to represent on some occasions. But to your specific question about ventilatory capacity and space and the use of earlier oxygenation, these two are clinically completely disconnected, in the sense that the primary reason for admitting a patient to the hospital wards at all with COVID-19 is for the provision of oxygen therapy, which doesn't require a ventilator or the intensive care to give. There is in fact a stage beyond oxygen on the ward that we call non-invasive ventilation, and beyond that again there is the intensive care where we would formally intubate a patient, pop them off to sleep and breathe for them for a period of time using a ventilator machine. So they're three very separate stages, but they are disconnected from each other in terms of when oxygen is administered. Over.
Thank you. That brings us on to our final section, and we're going to discuss now the impact of coronavirus on cancer and other health conditions. And I wanted to start, if I may, Secretary of State, with something that Simon Stevens told this committee on the 17th of March. He said there would be no impact on cancer treatment, but Professor Carol Sikora, who's a cancer expert, is worried about access to proton beam therapy, and there have been other stories. So I just want to check that you are absolutely certain that no urgent cancer treatment is being delayed.
Well, that is absolutely our policy. There was a question around proton beam therapy a couple of weeks ago, which we addressed, and as far as I understand it, that is now back up and running. That was to do with staffing rather than to do with patients being told that they shouldn't have access, and that has successfly been resolved. However, having said so, that's just on proton beam therapy at the Christie in Manchester. But there is a much broader point here. There is some oncology that it is important not to do whilst there is a widespread virus, because it requires the reduction in your immune system. And no matter how well shielded somebody is, to take somebody's immune system down to close to zero, which is what some cancer treatments require, and in the current circumstances when a deadly virus is prevalent amongst the population, that would be a mistake and the wrong thing to do. Even if we had all the capacity in the world, it's not a capacity question. It's disconnected from capacity. It's a clinical judgment. Then there is some cancer treatment which is non-urgent because some cancers grow extremely slowly over a period of years, and where surgery would be better done at a later date. So those are both, I think, correct policy decisions, obviously where the individual clinical decision is taken by the clinicians of the patient, but the policy in those two cases is to avoid at this moment taking forward the treatment. But there is one area where I'm really concerned, because we've also seen a drop-off of first presentations. And this is a really big worry of mine, which is that even though cancer treatment is ongoing now, and if you want to have if you need chemotherapy, then that's ongoing. If you need radiotherapy, that's ongoing. But far fewer people are coming forward. And this worries me, because we'd spent an awful lot of time over several years, time when you were Health Secretary and time I've been, driving up those coming forward for cancer treatment. And that has been brought to a juddering halt by this virus. And I want to send, we should all send a message to everybody who thinks they may have found a lump. Phone your GP and you will get treatment, and you will get safe treatment even during this virus. And I think that's something that we plan to do much more work on over the coming weeks.
So, I mean, you used the phrase come to a juddering halt. In some parts of the country, the referrals for the 2-week cancer target are down 75%, which would potentially mean we're missing 3/4 of the cancers that we would normally be picking up. Professor Richard Sullivan of King's College said there may be more deaths from the disruption of cancer services than from coronavirus. Is that possible?
Well, I think that's unlikely because the ongoing treatment is there. But we all know that early diagnosis is important in cancer, and so we've been very clear from the CMO set this out a couple of weeks ago that we look at the mortality impact of coronavirus, not just at the direct impact of coronavirus, where we read out those sad statistics every day, but also the impact of deaths because the NHS has been overwhelmed, which thankfully has not happened. The impact of deaths in this case due to other treatments not happening. And I just want to stress that the other treatments are available where they are clinically appropriate to do whilst there's a killer virus about. But we have seen the biggest problem is the drop off in people presenting. And then, of course, the fourth set of deaths which come through the socio-economic impacts of the measures that we're having to take. We look at all of those rather than just the direct deaths, even though they're the most visible. And it is something I worry about.
Thank you. Amy Callaghan.
Thank you. Secretary of State, I've got concerns around how charities like Click Sargent will be able to stay afloat and maintain their invaluable support to young cancer patients amidst this and after the crisis. Without these charities, there would inevitably be more pressure on the NHS, and it's likely young cancer patients would suffer. Do you have a plan to support these health centre charities to continue supporting patients?
Yes, we do. Yes, I think this is incredibly important. We have a plan both for direct government support of charities, which the Chancellor outlined, but also we've seen charitable efforts right across the country. The latest being the Captain Tom, the wonderful 99-year-old gentleman from Bedfordshire who's raised now, I think, £15 million. 18, I'm told, somebody's shouted from the other side of the office, £18 million, which is absolutely fantastic. But obviously, we're putting taxpayers' support in as well. I'd highlight at the same time hospices, which often raise a large proportion of their funds through shops on the high street, and the shops haven't been able to be open. So we're supporting the hospice sector as well. And I think that charities across the health and care sector obviously have always played a very important part in the provision of healthcare, and we've got to make sure we support them through these times.
Thank you. Luke Evans?
For all the hard work you and your team are doing. I noticed in your battle plan, one of the things that I think potentially was missing was when we talk about battle and in medicine, death is an inevitability and something you have to deal with. I just wondered, you've put in a Herculean effort to get the ITU spaces and the ventilators. However, a lot of people who will suffer from coronavirus and indeed other conditions will never make it onto the intensive care unit. So I wondered what sort of provisions you have for the number of people who may be dying at home. And I've got a few questions about that. Do you know the number of people who are dying at home currently, or have an estimate?
Well, we do know the number of people who die outside of hospital, and they very largely die at home. It comes back to the very first exchange with the chair on the number of deaths reported. They're reported through ONS because we have to collect the data from the death certificates.
So with that, I mean, a good death needs three things. It needs equipment, it needs medication, and it needs the staff to administer it. So in terms of equipment, a few quick questions. Do you have enough syringe drivers in the NHS to deliver medications to keep people comfortable when they're passing away?
Yes, we do. There was a challenge raised about this about 8 days ago, and we resolved. Actually, it wasn't as big a challenge as was made public, and we've resolved that. So yes, right now we do.
And the second one is with that's the syringe drivers deliver medication, particularly things like midazolam and morphine. Do you have any precautions put in place to make sure we have enough of those medications to be delivered?
Yes. We've got a big project to make sure that those sorts of medications, as well as the ITU medications that I spoke about earlier, that the supply chains, global supply chains for those medicines are clear. They are, in fact, those medicines are made in a relatively small number of factories around the world. So it is a delicate supply chain, and we are in contact with the whole supply chain.
And in line with that, morphine is currently prescribed per patient. The reason to do that is to stop it being abused. So I have to prescribe it for Mr. Hancock. However, in this situation, if you're going into a healthcare home, you may not want to waste precious things like morphine. Have you considered relaxing the laws around morphine prescribing for doctors and healthcare professionals so that there isn't waste?
That's something that we keep under review. I've looked at that particular point to reduce wastage of key medicines, and it's something that the supply chain, the supply team, in the department and the clinical team talk about all the time. I don't know if that's JVT's part of the clinical team, and he may want to say more.
Thank you.
No, I've nothing really to add on that.
Okay.
Okay. Thank you, Rosie Cooper.
State, thank you, Secretary of State. Dealing with cancer, am I coming through?
Yes.
Hello.
Yes.
Sorry. Okay. Secretary of State, I echo your comments about people, if they think they've got cancer symptoms, should go to the GP and get it dealt with. Early detection is all. But I think, notwithstanding the comments you made about certain types of chemotherapy, which reduce your immune system to almost nil, notwithstanding that, there'll be cancer patients right around the country who will be aghast at the disconnect between your words and what they're hearing when they see their consultant or oncologist. Operations are being delayed. I virtually attended an all-party group on radiotherapy last week where radiologists are being used in other departments and their machines are not being used at capacity. So people are not getting the cancer treatments as quickly as they could. We're not using the capacity we've got. So there's a huge disconnect between what you're being told and what's actually happening on the front line. And we should be using all our capacity as best we can. Will you please investigate that and make a statement? Because that, I know personally of several people whose treatment is being delayed. And finally, an aside, could you say whether clinical staff who've died working in the NHS, are their deaths being referred to the Health and Safety Executive for investigation?
Thank you. So on the first of those, what I set out is the policy, and there are different reasons why surgery or, as I was saying, chemotherapy might be delayed. In the individual cases you've got, please bring them. If you write to me and bring them to my attention, then I'll have them looked into. Absolutely. And the broader point that you're making, that it might not just be the ones who've been brought to your attention. Of course, I'll take that and talk to the NHS.
Secretary of State, we're getting them all over on Twitter, my constituents, personal friends of mine, former MPs. It is clear there is a slowdown in cancer treatment.
Well, yes, as I was saying, in some cases that's for good clinical reasons. In other cases, we'll make sure that we look into them, and I'll take that up with the NHS leadership. And on the sorry, can you remind me of the second point?
Yes, well, the
health
clinical
executive. No, the investigations are being done by the NHS, by the employers, because they're the ones who are on the ground to understand the circumstances.
No, should they not be sent to the Health and Safety Executive for an independent look at it?
Well, I'm not sure the HSE is the right body to do that, because we have bodies inside the NHS who investigate patient safety issues, and so we're doing it through hospitals and in consultation with the employer, but we need to make sure that they're done properly.
Can I just come in on that point, Secretary? I think the concern is that if, for example, someone had died because of a lack of protective equipment. Oh, Rosie, sorry, I didn't realise you wanted to come in. Do come in, Rosie.
Sorry, I
think we seem to have lost you. I'm sorry. Secretary of State, can you hear me?
Yes, I can. I think you were both making the same point at the same time.
Yeah, it was just if someone had died because of, for example, a lack of PPE, I think what people want to know is that it would be investigated by someone independent of the organisation that was responsible for providing them with that PPE, because there would obviously be a conflict of interest otherwise.
Yeah. Well, thanks to your work, we have that system in place, and so I think HSIB are involved in these investigations, but let me go and check that.
Thank you. Two final questions from Paul Bristow and Dean Russell.
Secretary of State, I'd like to ask you a question about motor neuron disease. Clinicians have noted that there are severe respiratory difficulties that motor neuron disease can cause, and believe that patients ought to be shielded as a result.
Yes.
But at present, it's not on the government's list of conditions for being extremely vulnerable.
Yeah.
Patients can self-register, I understand that, but many patients may not know this and therefore may miss out on the benefits. Is this something you're looking to review?
Yes, it's something that I've already reviewed, and my team have worked with the motor neuron disease charities on this to make sure that we get it exactly right. It's very important to get right. And my initial instinct was to say, well, of course, motor neuron disease should be on the list, but the clinical advice is that there are many stages of motor neuron disease, and whilst those in the later stages are almost always going to need to be shielded because of the impact of the disease on them, that isn't the case at all stages. And the thing about shielding is that it is a very significant burden on those who we are advising to shield. Not to leave your home for 3 months is very significant. And so, as you say, people can self-refer, and then it goes to the GP, and the GP can make the decision based on the advice, based on the clinical needs of each individual patient. So we talked to the motor neuron disease and some of the campaigners about that, and as far as I am aware, the advice I got back is that they understood and could see the point in making the decision that way. I'm completely open to putting all motor neuron disease, all people living with motor neuron disease on the list, but actually you can, once you dig into why not, you can also see the case the other way for some of those who live with motor neuron disease.
Thank you. Dean Russell.
Thank you, Chair. And I'm going to ask this question with my hat on as being a member of the Joint Select Committee on Human Rights. So if I may, I'm just going to read out the question that I've been asked as part of the committee to share. So it relates to people with autism and learning disabilities in mental health hospitals. Last year in November, the committee identified that there were human rights were being abused for people with learning disabilities and or autism in mental health hospitals. And as part of that, one of the concerns is that with coronavirus, family visits are currently being restricted, and routine inspections have been suspended, which in turn potentially increases the young people's isolation and also makes them more vulnerable to abuse of their rights. So I wanted to ask on behalf of that committee, what's being done in response to that situation, please?
Well, this is obviously a very difficult situation. Many people who are inpatients in these circumstances, not in all cases, but in many of the cases, also have a higher risk of morbidity from COVID-19. So the decision on an individual institution basis to restrict visitors is an understandable one in some circumstances, but it's got to be done right. And it's something that I worry about in the same way that I worry about not enough people coming forward for cancer treatment. There are many consequences of the decisions that we've had to make, which are difficult. There's an overall program which remains working and in place to try to reduce the number of people in inpatient settings. That is a very important piece of work that is that's ongoing.
Thank you. I appreciate the answer. Thank you.
Secretary of State, you've been very generous with your time this morning. We appreciate your making incredibly difficult judgments on behalf of the whole country, and you've given us a couple of hours to share your thinking. So thank you very much on behalf of the committee for giving us your time this morning, and very best of luck to you and all your team in the difficult days that lie ahead. I declare the session closed. All aboard.
The proceeding has ended.